All right. I turn the lights off. No sleeping. All right, so this PowerPoint jumps around just a little bit, so I'm sorry that it doesn't, to me, it doesn't quite flow like the other ones have had, or that they have. So just kind of bear with me. Like I said, it kind of goes all over the place a little bit. So the biggest thing we're going to talk about is the anatomy and physiology behind this, because a couple of things change pretty drastically when it comes to the patients you're going to take care of. So 9 months of pregnancy, right? Technically, it's closer to 10 months at full term, okay? But obviously, there's 3 3-month trimesters. That first trimester is kind of that time. Some people may not know they're pregnant for the first half of that trimester, right? And of course, we've all heard stories of people who go the entire length of pregnancy and supposedly have no idea that they're pregnant, okay? I think they made a show about it, right? I think it went for like 9 seasons. How you keep finding people who are that stupid, I'm really not sure. Yeah, I didn't know I was pregnant, yeah. So organs that change, right? The placenta, this is going to be the organ that basically is the filter and the storage between mom and baby, okay? That placenta needs to stay 100% attached to the wall. If it comes detached in any way, shape, or form, we're going to talk about the different times that it can cause some pretty serious problems. But anytime that baby's getting anything from mom, it's coming through the placenta, okay? So baby gets its oxygen, nutrients, just about everything filtered through the placenta. Anything that mom has in her bloodstream, baby gets, okay? There is protocols in Spokane County for us to deliver Narcan to newborn babies. Because if mom's been doing heroin the entire pregnancy, baby is high on heroin as soon as it's born, right? It's been high its entire life as long as mom's been doing heroin. So we have protocols to give Narcan to newborns to help them breathe a little better, okay? It's much, much less than you're going to give an adult, right? We're talking very, very small increments because of the fact of the chance of making them go into withdrawals pretty quickly. So the umbilical cord, this is going to circulate that blood, right? What is your umbilical cord made up of? Does anybody know? It's just a cord. But what else is it? Did you stretch this morning? Because I thought of you reviewing this PowerPoint thinking, man, that's going to be a lot of push-ups. Anybody know? Well, it's got like cartilage pieces, but it has an artery and it has a vein. So when we get farther into this, mostly with the story towards the end of this, you can, as advanced EMTs and paramedics, we actually start IVs in the umbilical cord, right? You just put IVs in the end of the umbilical cord after we've cut it, and it circulates fluid to and from baby, okay? Amniotic sac, so this is the fluid that allows the fetus to float around, right? Nice, cushiony, warm environment where they spend almost 10 months of their first part of their life, okay? Nice, good temperature. That's the big thing we're going to talk about is once these kids are born, maintaining their body temperature at least about 99 degrees, okay? That's probably the biggest downfall to me to delivering kids in the field is your delivery room, wherever that's chosen to be, has to be 99 degrees Fahrenheit, okay? So that means the back of your ambulance needs to be 99 degrees, okay? If you're not sweating, you're clearly not warming the baby enough, okay? So, oh, it's a cute picture. Baby, placenta, cord, sac, giant bowling ball. We're going to call that more than once. So the couple of changes that happen, the cardiovascular system, now you have another thing introduced to the body. You'll hear me call it a parasite because really it is, right? It doesn't ask, it just takes. So mom's blood volume has to increase, right? Which is why you hear a lot of people say moms glow, right? That red, flushed look of their face is because their blood volume has increased substantially, right? 50% more, okay? Which therefore means their cardiac output increases, therefore it means their heart rate's going to increase, okay? So pregnant females, you anticipate a higher blood pressure, just a little bit, right? We're going to talk about hypertension here in a second, and then a higher heart rate. Make sense? On the respiratory side, because of the fact now you have this parasite who's taking oxygen away from your bloodstream, mom has to increase the oxygen demand and consumption to make sure that she's compensated as well. So the minute volume increases by about 40% as well. Make sense? So blood volume increased by about 50%, and minute volume increases by about 40%. Why is this so important? Why do we talk about blood volume increasing? Like, it's good to know, but you, as a medical provider, when might this be a problem? How was shock? Okay? Okay, so I like that. That's one component. If you're losing a lot of blood, you're losing a lot of blood for two. What else? Remember those stages of shock? If I give you 50% more blood, now your signs and symptoms don't appear until you've lost all of that 50%, and then you start working on your own blood volume, right? So now you have to recognize signs and symptoms of shock early on. Do we ever deal with pregnant females who are trauma patients? All the time, right? I've seen more trauma patients or trauma pregnant females than I've delivered babies in the field or dealt with pregnancy-related emergencies, right? They wreck a car, they're in a car with somebody who wrecks a car. Domestic violence is still really, really common. All of those things, we see these patients on a pretty regular basis, okay? So hormones, right? Ligaments become more elastic, a little more vulnerable to injury. We don't see a lot of those, but it's definitely a chance. Additional weight can lead to back problems and balance issues. That's why they always fall over. Pre-existing medical conditions can be exacerbated, especially if they've got, if they already have diabetes. It can become a problem then trying to compensate for the fact that you've got two people, right? Cardiovascular problems, respiratory problems, all these things can kind of weigh in on this. This is basically just a look at all the things we just talked about on a picture, right? How far along do you think she is? Far enough along for you to pass it off to your partner so you don't have to deliver in the field. If I roll a thumb, if you look pregnant, my partner's going to take care of you. I'll drive real safe to the hospital. So, supine hypotensive syndrome. Make sure you write that down, okay? The placenta, the amniotic fluid in baby at about, by the third trimester, we're talking about 24 pounds, okay? It's a huge bowling ball, okay? So the last thing you want them to do is you do not want to lay these patients flat. When you do, that, I like how it says mass. That's like a horrible term. The parasite compresses the inferior vena cava, okay, which now decreases cardiac output, okay, because not as much blood is returning to the heart. That makes sense? Patient gets dizzy. It messes with their blood pressure. Now, we're talking all about the bad things with mom. This also affects baby because now there's not enough blood getting out to baby. Okay, so how do you fix this problem? How far? Yeah, 15 degrees, right? A blanket or a pillow underneath the backboard to tip it to the left-hand side, all you got to do. Okay? You don't want a lot because you don't want them compressing against those straps all the time, but just a little tip to allow that bowling ball, the gravity, to kind of pull it off to one side. We prefer that you tip them to the left. Yep. What's that? There's a digestive side to it, I guess, where if you tip them, there's more room for that mass to go that keeps it away from the stomach or something along those lines. I've always looked it up, and it sounds like the old ambulances, all the stretchers were mounted on the right-hand side of the ambulance. So if you tipped them to the right, they were faced against a wall. And so we always did left-hand side, which kept them away. So, I mean, I don't know if that played a part in it, or if there was something about a digestive component about causing less nausea if they're on the left side, not the right side. So I think there's a lot of components to that. But if you see something specific in a test question, they belong 15 degrees in the left lateral recumbent position, right? If it just says on their side and there's no other specific, then the answer is on their side. But if they give you a choice between right and left, then the answer is left. The only time I could see you having to dive deeper into a test question like that is if they had a fracture on the left-hand side, right? If they threw, and I've never seen a test question like that, that's kind of a pretty intense test question. But you got a femur fracture on the left-hand side. You got a mom who's 9 months pregnant. What side are you going to put her on? In that case, of course, you're going to roll to the right side to keep the weight off of the fractured extremity. So pregnant and potentially pregnant patients should be placed flat on their backs. Now, that's a little bit excessive because early on, we're not talking about something weighing 25 pounds, right? So If you know they're pregnant, you could definitely keep them on the left-hand side just to be careful. 15 degrees is about all you need to do. These patients, there's a test question that seems to get students. If the patient has enough injuries to justify a backboard, you still have to backboard them, right? You're not going to bypass backboarding just because they're pregnant because you don't want to lay them flat on their back. Lay them flat on their back, get them strapped to the backboard, roll that backboard 15 degrees to the left. Does that make sense? Don't get caught up in, well, maybe we shouldn't backboard them because of the fact they are pregnant. Some places we're getting rid of backboards anyways, but in the NREMT, they're not quite that far yet. Okay, so enough mechanism of injury to think about a spinal injury, then put them on a backboard. Just make sure we tip it to the left-hand side. All right, comes the fun part. Here's how to catch. It's easy. So 3 stages, and there's plenty of test questions that talk about these stages. Okay? First stage starts with regular contractions and ends with cervix that's fully dilated. Your second stage is when the baby enters the birth canal and is born. So second stage starts with a cervix that's fully dilated and ends with the complete birth of baby. The third stage starts with once the baby is completely born and ends with after the placenta has been delivered. Okay? Now, as EMS providers, we assume mom is in first stage. There's no way for us to actually prove it unless she's got full contractions. Okay? The time that we know she's in second stage is when she starts pushing and starts crowning. Okay? The reason why we talk about this is there's no way in EMS for us to check to see if the cervix is dilated to a 10. Okay? It's not our job. Don't assume. Don't do it. Don't ask about it. Leave it alone. Okay? Your job in all of this is protect mom, okay? Treat mom, catch, and then treat mom and baby. Okay? Real easy. I save the bad stuff, what can go wrong, towards the end because it's depressing. Okay? So we're going to talk about normal first. Make sense? Cool. So in that first stage, there's what's called, what? It's like 6 words to write. Write faster. We're going to be here till 1 o'clock. Chest pain or something? Looks like a lot of caffeine to me. We good? All right, so Braxton Hicks contractions. This can occur in that first stage, right? So these are, we've heard them called like practice contractions or fake contractions. This can usually like scare mom to thinking she's going into labor. They're inconsistent. They're not regular, right? So it's just like a contraction that happens here and there where there's not a lot of pain. When we went through like our doctor for my daughter's birth, they told us Braxton Hicks contractions you can talk through, right? They're not really painful. They're not debilitating like regular contractions are, okay? Regular contractions means you stop breathing, you stop talking, the contraction finishes, and then you can go back to what you were doing. Braxton Hicks contractions, most patients will just talk through them, okay? Now, this is pretty much the warning sign that as those are getting closer and closer together, we're probably getting closer and closer to regular contractions, which means we're looking at delivery. Okay, lightning is that feeling that mom feels when that fetus moves from high in the abdomen down towards the birth canal, right? The baby actually drops to kind of get ready for delivery. Now, we're going to talk about the questions that you ask mom when you're going on these patients. The big one is, do you know of any positional issues with baby, right? When baby's high up in the abdomen, a lot of times you'll hear them say, well, my baby's breached and I'm supposed to go to the doctor, and they're supposed to attempt to turn the baby. They can do that. They take their hands and they push on the stomach and get the baby to flip the direction they want it to go, right, which is head down. The funny thing is about 80% of the time, they push baby to go head down, and then like 2 minutes later, the baby goes, whoop, and flips back where it wants to. Until it drops in that birth canal, it'll flip and do circles all day long, right? It'll be head down, head sideways. As it gets bigger, it gets harder and harder to do that. So they want to try to position it head down. So when it gets closer to full term, when it drops into the birth canal that it's head down, okay? Oh, I could only imagine trying to rotate a 25-pound bowling ball in someone's stomach. I thank God every day that men don't have babies. Yeah, me too. It's like the first thing I say when I wake up. Thank you. It's going to be a good day. So contraction of the uterus produce normal labor pains, right? How do you feel uterine contractions? Anybody know? Yeah, you just stick your hand on their stomach, and you can actually feel that uterus contracting, right? So when we're looking at like uterine contractions, you just stick your hand up on mom's stomach, and when she's going through contractions, you can normally feel that like cramping contraction feeling, right? They feel it worse than you do, but you can actually feel those. We're going to talk about how you time them shortly. James, you okay over there? Yeah. You look a little pale, lightheaded. I haven't even shown pictures yet. So, characteristics of labor pain. So, we care about how long the contraction is and what is the duration, okay? We also care about interval and frequency, okay? What you want to do is when one contraction starts, you're going to start a clock, okay? When that contraction ends, you're going to hit like a lap timer, right? Because you're going to time one more thing. So you care how long they last, and then you care how long from the start of one contraction to the start of the next. Okay? If you're on scene and mom's like, I think I'm going into labor, and you're like, yeah, okay, let's do some stuff, right? Let's take some vitals. And if it lasts longer than 30 seconds to a minute, and they're 2 to 3 minutes apart, you are going to deliver a baby. Okay? If it's imminent delivery, we don't leave. I will tell you in all seriousness, the last place you want to deliver a kid is in the back of your ambulance. Deliver at home, deliver in the driveway, deliver somewhere else but the back of your bus. There's not enough room there. You're driving down the road. You start yelling. Mom starts yelling. Driver drives faster. It's just not a good idea. Okay? We're going to talk about the circumstances where you do load and go, but if it's a normal delivery and everything is going fine, deliver on scene, and then you can transport mom and baby to the hospital.
So if baby is born, are you waiting for, you're still going to take them to the hospital afterwards? Okay.
Yep. And we don't need a second ambulance. We never separate mom and baby, right? Transport them together. Yeah, that's a real bad idea. Don't worry, you're going to go in one ambulance. We're going to take your daughter in the other one. Good luck. Yeah. Why don't you go to Cattails and take the next cub away from one of those tigers, lions, whatever, and see what happens. It'll be fun. Yeah. Why does that not shock me? So, if water breaks prior to you getting there, one of the questions we're going to ask is, what did the fluid look like? Okay? It should be fairly odorless and it should be clear. We're going to talk about meconium staining, which is extremely dangerous for baby. What is meconium? Yeah, it's poop, right? If you want to use the term meconium happens instead of shit happens, you're more than welcome to, right? It's just when the baby poops. Now, why would the baby poop? What do you think? What is an indication of? Not necessarily. What do you think? Stress on baby. Right? So a long delivery or some sort of trauma or something that causes stress to baby, the baby poops inside of that amniotic sac, and now what are they breathing most of their life? Amniotic fluid, right? Which if they have meconium staining, they start breathing in, and I will tell you that meconium is the thickest, stickiest, nastiest stuff you've ever seen, right? I kid you not, you could take that, put a picture and hang it on your wall, and it will never fall down. Right? It will stick there through fire, tornado, hurricane, rapture. Yeah. And babies, their first couple diapers are meconium, right? That's totally normal. You just don't want that when they're trying to breathe. Okay? When they come out, it's pretty easy to tell it's meconium staining because it's all over their face. Right? It's like stuck to their head, their face, it's in their lungs, it's in their mouth, it's in their airways, and it causes some pretty big issues. It just depends. Depends on, was it a traumatic delivery? Was it a long delivery? Was baby stuck? Was it breech? I mean, there's all kinds of problems. Yes, ma'am. Sorry. It's in that 99.9% of the time nothing goes wrong. It's in that 0.1%. It's nice if it happens in the hospital, right? Because the biggest concern is a lot of those kids end up, in the ICU because the biggest concern is like infections and aspiration and stuff like that. So, I mean, they clean it off. It happens every once in a while, like right towards the end of delivery, where you might catch it before they take a breath. Once they're shoved into that birth canal, their chest isn't contracting, right, because they're smashed. So they're not really breathing. That's why when the head comes out, one of the first things you're going to do if there's a problem is suction. There's a big change, and I can't remember if your textbook follows it or not. We no longer suction babies unless we know there's a problem, a lot of blood or meconium staining. If their mouth is full of amniotic fluid, do you really care that their first breath is amniotic fluid? They've been breathing it for 10 months, right? Really, I mean, it's not going to hurt them at all. Where you get concerned is if there's a lot of blood and meconium staining or vomit or anything like that that's now in their mouth and they take a big deep breath, you don't want that going to their lungs. Libby, go ahead. Not usually. We're going to talk about how to keep this as clean as possible. Not usually. Usually you just tell the fire department, hey, we're going to transport. Clean up. Brandon's like, the hell you will. Brandon's like, that's why I went to officer school, so I don't have to clean. All right, so second stage, this starts at full dilation of cervix, which I talked about. You're not going to know, okay? If mom is pushing regularly, that's going to be a problem, okay? Make sense? So contractions start increasing to be pretty frequent, okay? It's like mom she'll have a contraction, she'll breathe, and then she'll talk for like 1 or 2 minutes, and then she'll have another one, and then they start linking together, okay? Mom will usually have an urge to either push or move her bowels, right? It's the same feeling for them. So you ask questions about, do you have the urge to push, okay? Now, this bottom one, I will tell you a lot of test questions. They're going to be asking you, they're going to give you the scenario, and they're going to give you 4 options like always, but 2 of them are totally ridiculous. The 2 options they're going to get is A, do you transport? B, do you stay and deliver? Does that make sense? A lot of those test questions, that will be what you're trying to decide. Is this a deliver unseen, or is this a can we get to the hospital in time? Okay? The sign of imminent delivery, contractions lasting longer than 30 seconds to a minute, and contractions 2 to 3 minutes apart, or if baby is crowning, which means when you check the vaginal opening, you can see baby, okay? If that's the case, you're not going anywhere, okay? You're going to deliver this kid on scene, okay? So contractions 30 seconds to a minute in length, and an interval about 2 to 3 minutes apart, or if baby is crowning, okay? Don't worry, it's a drawing. The real pictures are coming up. Cork it. Okay, any problem with this? What do you think? Any complications? Nope, that is perfect. That's what you hope for, okay? We call this a cephalic delivery, cephalic meaning head first, okay? We prefer them to be nose down. Nose up doesn't cause that big a problem, but we prefer them to be nose down, okay? What's that? Gravity and pull could easier control the head, just stuff along those lines. But it doesn't really, baby comes up, nose up, it's not a huge deal, right? Now, this, for one, will get your adrenaline going, right? You're like, oh, God, they're crowning. I will tell you it gets scarier until you can see the neck, because nuchal umbilical cords, or umbilical cords wrapped around the neck, are fairly common, okay? The nice thing is, most of the time, once the neck becomes seen, you check for an umbilical cord, right? If it's there, if you can, just take your finger, grab the umbilical cord, and slide it off their neck. That's it. Okay? I will tell you that the biggest concern you have at this point is stabilization. Okay? They do not have enough bone structure to protect their own bodies. Okay? We're going to talk about the whole procedure here in a second, but once the head comes out, it's all about supporting the head. Once the shoulders come out, this delivers extremely fast. Okay? And you're wearing gloves, and this is covered in a very, very slippery substance. So do not, under any circumstances, drop a child. If you do, you always fake a seizure, so you have a reason to drop the child. Like #1 rule in EMS. If you drop a baby, fake a seizure. Very important that you write that down. Okay, third stage, after baby's birth, contractions, this is the worst part, right? You okay there, Mahaffey? That's Mahaffey's next tattoo, I guarantee it. Drop baby, fake seizure. Step 1, drop baby. Step 2, fake seizure. Mm-mm. Well, we're going to talk about that here in a second. Don't do that. Yeah, do the Mahaffey right next to their head. We'll talk about that here in a second. So here's the third stage. Re-engage for just a second. Pay attention. I know it was funny. Focus. Okay? So after baby's born, contractions resume. Right? So it's contraction, baby's born, oh, it's a boy, and then it starts over again. Right? What those contractions are trying to do is one of two things. One, it helps deliver the placenta. Two, it's trying to force that uterus back down to a smaller size. Right? That uterus is massive. It just housed a, 8, 9 pound baby. Right? Hopefully like 6 or 7 pounds. Make sense? The doctor told us this is one of the only few times, right after delivery, if you push on mom's belly button, don't do this, right? Experience. If you push on mom's belly button, you can touch their spine. There's no organs. They're gone. They're basically displaced all the way out to the sides. There is nothing between belly button and spinal cord. Their stomach cavity is literally a hollow cavity, right? So what happens is the contractions start to try to start bringing that uterus back down to a smaller size. All you want, yeah. It's your body, I don't care, right? If mom's sleeping, you could just do all you wanted to know. Yeah, I wouldn't do both of those in the same patient, right? Choose one or the other. Okay, the third stage usually, and it says usually for a reason, lasts 10 to 20 minutes. Okay, we want to make sure the placenta gets delivered, but you never withhold transport waiting for the placenta to deliver. The other thing that you never do, and I say never because it's going to be part of the story later, you never ever pull on the umbilical cord to try to get the placenta to deliver. Okay? Under no circumstances. Two things can happen. You can actually, if you pull and it stays attached, you can cause the uterus where it's attached to actually pull out the vaginal opening. You can flip their uterus inside out. Okay? That's life-threatening. The other one is you could pull it and a piece could rip off and stay inside mom, and that can be life-threatening as well. Okay? You just let the normal delivery process happen. Okay? That's the placenta. Easy? That's what I thought. All right. So here's patient assessment. So these are the questions, the vitals, and so on. The #1 thing you're concerned about is your assessment is initially based on, are we going to deliver here, which is what we're talking about with imminent delivery. Okay? Are we going to deliver baby on scene? If we're not, put them on an ambulance and drive like hell to a hospital. Safely, of course. Of course, Mahaffey. One of the ones that I missed was she was 9 months pregnant, full term. This was her 5th child. And I was like, oh, please, God, no. Right? Because at that point, it's just like, baby, right? The first one takes hours. So full-term pregnancy, 5th child. She's having contractions 2 to 3 minutes apart. We're like, oh, this is going to happen. Got her into the wheeler in the ER, right? And she's like pushing, and we're like, let's speed this process up. We turn the right-hand turn at Holy Family to go to the ER, and the ER is like, no. She goes up to the OB floor. You go get in the elevator. And I'm like, the hell we are. I've seen movies, right? That's where they get delivered. Elevator gets stuck. I have to deliver. Like, no. So get in the elevator, thankfully, and literally put her in the bed, like in the OB room, put her on the bed. I grabbed the stretcher, wheeled it outside, walked back in, and doctor was holding baby. And I was like, boom. Problem solved. Sean's a great name, just in case you're wondering. Here, sign this piece of paper. I got to go home without delivering a child. I'll take traumas and saves all day long, right? I don't need no stork pin all over my uniform like the rest of these guys. No thanks. So, first things first. I love when I ask, like, what's the first thing you're going to ask mom? And people are like, how far along are you? Are you pregnant? No, the first thing you're going to ask is, what is your name? Right? Because you're going to be fairly close with this individual. Okay? I'm Sean. What's your name? Here's what's going to happen, right? How old are you? When's your expected due date? Is this your first pregnancy? Okay? We're talking about hours for first pregnancy, and then the time gets shortened as we go with multiple pregnancies. It's not uncommon in some of these areas around Spokane where you say, how many times you've been pregnant, and they start talking about, 6, 7, 8, 9, 10. And you're like, good Lord, you are 27. How do you have 14 children? Okay? Yeah, that's sad. We're going to talk about that here in a second. Super sad. Okay? Why do we care if the patient has seen a doctor? What do you think? So to know like how she's doing. Yeah, this increases that 0.1% like 40%. Okay? They've never seen a doctor. We're increasing the chance that you're going to have a problem. Okay? That's sketchy. Because you don't know if they're head up, head down, if they're full weight, if they're premature, if they're, you have no idea.
Isn't that becoming more and more popular?
Yeah. We're also, life choices. Why was not immunizing your kids more and more popular? Yeah. We also are starting to see more and more midwives in the field, right? You show up, they call 911, and they show up and they're like, well, I don't want to go to a hospital, I'm a midwife. And my answer is, you called 911, therefore I'm the professional and she's not, right? We don't deliver babies on scene because there's a midwife and they want us to stay there. If you call us, your midwife no longer has any say. We are the professionals, right? The same thing goes for water deliveries. Sorry, you called 911. I'm not delivering your baby in a bathtub. That is your personal choice if you wanted to. But since you called us, there must have been a complication where, therefore, we're transporting. And if they are adamantly refusing, you pick up the phone, you call medical direction, and you talk to a doctor. Right? That's the one thing you have to fall back on. Because we have had circumstances where midwife is telling you, you're not transporting mom. And there is this darn near physical altercation where you're trying to leave because it's needed, like a breech delivery, and the midwife is saying, no, you're going to deliver here. And you're going, no, we're not. Call a doctor. Right? Because that doctor will be like, you're either coming here or you're staying there. I guarantee every single one of them says, you're coming here. Make sense? Midwife is a, here in Washington, there's actually no certification, but it is a trained, like, home delivery, right? Not a doctor, not a nurse. They have training. They can work through it. It's like a natural delivery. Here in Washington State, any person in this room can be a midwife, right? There's no certification. Which is why we look at the midwives here in Washington State and go, there's some great midwives. Again, that's your personal choice. If you want to deliver in a bathtub, there's great science behind it. But if you called 911, we now going to do this our way because you called us. We're the professionals, right?
Is there a point where you could have them sign a refusal? I mean, I don't.
If you contacted medical direction, they said go ahead and leave them, then yes, sign a refusal. Before you not transport these patients, call medical direction. Yeah, make that because you do not want the liability on you. Put it on the doctor. That's what they're there for. Okay? So, name, age, expected due date, 1 or 18 pregnancies. Have you seen a doctor? Okay? And then when did your labor pain start? How long has this process been going on? Make sense? Whoops. Oh, God. Patient feels the urge to push or move bowels, right? Are you feeling the urge to push? Okay? Now, this question can be fairly uncomfortable to ask, right? Because this is that point where you're going to become fairly personal with your patient. I will tell you there's a tactful way and a non-tactful way to ask this question. The easiest way is, ma'am, I need to check to make sure that your baby is not crowning, which means we're going to deliver here. Will you do me a favor? I'm going to give you a blanket. Will you please remove your pants and your underwear, cover yourself with a blanket, and then prop your knees up and spread your legs apart. I'm going to check for crowning, right? If you see crowning, don't make any, like, remarks, right? Like, no, please, God, not today.
One of those ones where you want to cover your face from hers so you can look and be like,
Yeah. Stop it. You stretching the happy? You're getting closer and closer to push-ups. People just like, they just ask me like, you know, they don't know how to be like, okay, here's the deal. Here's what's going to happen. Here's a blanket. They just be like, okay, well, here's the deal. Take off all your clothes. And they look at you and you're like, that could have gone different. Let's start over. Hi, I'm Sean. Feel for uterine contraction. Where is the fundus? I love this question, right? Because there was a lady that used to work for us, Claire, who was my favorite people in the entire world, would ask a guy, right, to be like, if the girl next to you was pregnant, I want you to place your hand on the fundus. And they're like, right, because it sounds real worse than it is. Where's the fundus at full term? Anybody know? What's that? It's clear up here, right? The fundus is the top of your uterus. The 26 weeks, 27 weeks, all that stuff, that's how many centimeters there are from the pubis bone to the top of the fundus. Every week, the fundus moves up a centimeter, right? So at full term, the fundus is clear up here, okay? We're going to talk about massaging the fundus because that's a way of controlling after birth bleeding. And what you do is you actually take two hands and you massage the fundus. By doing that, you make the uterus actually contract and start to get smaller, which decreases the amount of blood. Okay? So uterine contraction, stick your hand up on the top of the uterus, and you can actually feel that contraction feeling. Okay? What vital signs do you think are important? All of them. Right? Blood pressure, heart rate, SpO2, respiratory rate. Could you check your glucose? Most definitely. Right? All those things are still just as important. Okay? This was my dad's saying. If the baby's crowning, you ain't leaving. Okay? That's what crowning looks like. That's what it should look like. Okay? Findings that indicate the need for neonatal resuscitation. Okay? That's the bad stuff. That's the 0.1%. No prenatal care. If baby is premature, any labor induced by trauma, and anytime you're dealing with twins or more. I think there's more, yeah. Make sure you leave plenty of room because there's a couple more. Good? Next list, history of pregnancy problems. The term I want you to write down, but leave yourself a space to define this, is placenta previa. Okay, we're going to talk about a couple of specifics where you're going to see a lot of test questions. So history of pregnancy problems, like known placenta previa or known breech presentation. Any labor induced by drug use, especially narcotics, because baby is now going to be addicted to and require those narcotics. Okay? And if you know that the water's already broke, meconium staining when the water breaks. Hey, look at that. Okay, perfect. You're probably not going to know. But when they come out not breathing, you're going to attempt to fix the problem, whether it's narcotics or not.
So would you just have to kind of guess, though, whether to give Narcan or not?
I'd have to look at our county protocols, but I think we have to have a pretty darn good reason, like the fact that it's known that they are. I'll have to look at it.
I mean, what if you looked and they've got, like, you know, the messed up veins and everything
Yeah, if they had track marks and stuff, it would probably be a pretty good indication, but. With those patients? Absolutely. Yeah, that usually starts involving CPS and law enforcement and all kinds of stuff. Got these? All right, so normal childbirth, right? EMTs do not deliver babies, moms do. Okay, that's actually Dan Limmer's bullet point, which I had to put in red because it cracks me up. Okay, you just catch. Okay, again, your primary role is to determine, are you going to deliver this on scene, or are you going to head to the hospital and the hospital is going to take care of it? So here's what you do. If you decide that the need to deliver on scene, here's what we're going to talk about, kind of that procedure. Okay, very first thing is start controlling your scene. Okay, get people who don't need to be there out of the room. Okay, dad, if he's a problem, go give him something to do, right? Like boil water. Okay, when he comes back with a gallon of boiling water, go, great, I need 7. Right? If he's going to be a distraction, he goes away. Okay? Grandma, grandpa, all those people can try to control your scene as much as possible. What personal protective equipment do you think you're going to be wearing? Everything. Okay? You do not need to wear an N95, but you probably should be wearing a mask. Right? Now, there's a lot of fluid. Okay? So it's a protection from that against you, but it's also a protection of baby against you. Right? Mom needs to go on a bed or on the floor or on an ambulance stretcher that's lowered to the floor. Okay? You want mom as close to the floor as you can get her. That is exactly the reason why. Yeah. Yeah, in case you have a seizure disorder you can't control. Okay, we talked about removing clothing. Position your assistant. Okay, this should be a medically trained individual, not like you just grab, the little brother and be like, hey, come here for a second. Right? This needs to be a medically trained individual. Okay, you are always working with a partner. Get the OB kit. We're going to talk about the components here in a second. You need to make your environment no less than 98.6 degrees. Okay? That's the coldest baby has ever been. Mom's temperature usually runs closer to 100 anyways. Okay? So start increasing the heat. Turn up the heat in the house, whatever you got to do. Make sense? This is all the easy part. Yep, we're going to talk all about that. Like I said, this is the start. Don't worry, there's more. Okay? These are the different towels or blankets or 4x4s or whatever you're going to use. Okay? And once they become soaked with blood, you replace them with a clean one. Okay? Which means you need lots of them. Okay? Lots and lots of blankets and towels and so on. Okay? This is a pretty standard OB kit. What do you notice is the most common tool in the OB kit? Gauze. Right? That's not gauze. All of this is gauze. Okay? Umbilical cord clamps, booger sucker, okay, nasal aspirator, scissors, bag for placenta. We're going to talk about that. What is that? No. It was a valid guess. What is it? What do you think? What? It is a hat. Number one place a baby loses their heat is their head. Okay? So we dry them, we cover them, and we put this little cool beanie on them. Whoops. Make sure you position, when you're going to deliver, make sure you have a constant view of the vaginal opening, right? Because that's where baby's going to come from. Okay? Be prepared for the patient to experience discomfort. Shocking. Right? Yeah. I feel like that's a little over the top. Provide emotional support. Don't worry. Everything will be just fine. Yeah, right. Yeah, but when your hands are going like this, she doesn't believe you. Yeah. Yeah. Oh, please no. Please no. Please no. Okay. So keep some up mom's head, right? This is a good place if dad is not a problem. It's a good place for dad, right? Go put him at mom's head. Comfort your wife. Comfort your girlfriend. Whatever. Don't assume those things either. Just be like, and this is. Oh, it's Bob? Great. Bob, go to the head with baby. Okay? Position the gloved hand at the vaginal opening when baby's head starts to appear. Okay? So as it crowns, you just put your hand. This is not a go back where you came from kind of push. Okay? You just put your hand on their head and provide a little bit of back pressure. What you don't want, if you don't do that, when mom pushes, we have what's called an explosive delivery, and there's lots of bleeding, lots of tearing, and it can be critical to mom. Okay? So the one hand just goes on the baby's head for delivery. Now, most of us will put our hand turned this direction so it can just stay there when we place our second hand when we go to grasp the top of the kid's head. Okay? So a little bit of back pressure. Okay? You girls okay? What? Yeah. Slant on one. Ready? If the amniotic sac has not been broken, you can just use your fingers and puncture that membrane. Okay? It'll be pretty obvious. So if baby hasn't, if the amniotic sac hasn't broke, you just take your fingers and you basically, it'll tear just like a piece of paper. Right? You just tear it so that that sac opens up. Okay? Once the head delivers, this is the easy part, right? Once you have access to nose and mouth, you want to look to see if there's any reason for suctioning. Okay? If there's no reason, like there's no blood or there's no there's no meconium staining, don't suction under no circumstances. Right? I don't care what your textbook says. I couldn't remember if this textbook was up to date or not. The NREMT is you do not suction unless there's a known problem. Okay? We're going to talk about the dangers of suctioning here in just a second. Once we get to the neck, you care if the umbilical cord is wrapped around the patient or the baby's neck. Okay? Now, helping deliver the shoulders does not mean pull. It just means you're going to provide a little bit of baby will come out nose down, right? When it gets to the shoulders, it actually wants to rotate. Okay? It's going to do it naturally, but you just kind of follow that rotation. Okay? Once an arm comes out, you want to drop a finger between drop a hand between your fingers. Okay? And that gives you really, really good stability of hanging on to baby. Okay? And then I will tell you from that point on, it's like one push and baby's out. So you're just going to go right from that and you're just going to lay it right down on the nice warm spot that you've created. Okay? Always support the baby. We talked about suctioning if it's needed. Note the exact time of birth. Okay? That's pretty important. Make sense? It's easy. Okay? This is that hand I was talking about, right? Support the infant's head. Baby comes out, it rotates. Okay? This is that finger I was talking about. Drop that arm between your fingers so you're hanging on to it. And then once it's out, look at how nice and smiley and cute it is. It never looks like that, I guarantee you. Okay? And then this thing goes like to the blanket because you're going to wrap it in blankets, dry it off, and then you're going to give it to mom. Okay? We're going to talk about that here in just a second. Okay? Now let's talk about neonates. See how ugly they are? My daughter's gorgeous, but that thing got a little, just kidding. She was cute no matter what. And 18 pounds, 14 ounces, or 18 pounds, 8 pounds. Sorry, good Lord. That's a huge, it's like my kid right there. Okay, so assessing the neonate. As soon as they're born, your number one priority is make them breathe. Okay, 18 pounds. God, can you imagine? You think a 3-year-old weighs 18 pounds? My daughter is barely over a year, and she is 25 pounds. Try again. Don't have children for more than one reason. Can't deal with 2 of you. Because you'll be like, you know what you should do when you grow up? An EMT. Go see Sean. I'll be like, God, you're my halfies kid, aren't you? And I'll have to fail it just because of its dad. True story. Touche, my friend. All right, so protocols usually call for nothing Noting ease of breathing, heart rate. We're going to talk about the ABCAR score. Okay? Before we get to the ABCAR score, your number one priority is, are they breathing? Okay? Babies, that includes pediatrics all the way up till they start becoming little adults, their body is based on their respiratory system. Okay? Breathing is the biggest thing we care about when it comes to babies. Okay? ABCAR score, okay? There is 85 multiple choice questions on your next test, and then there are 15 fill in the blanks. How many are on the board right now? Yes. Weird. It is in the book. If you would have read the chapter prior, you would have seen it. Yeah, yep. Yeah, this right here is your blank diagram on your next test. Okay? I'll give you these letters. Okay? You got to put everything else. Say again? On what I got rid of. Well, maybe I gave you all of these. I think I did give you these. And then you got to do these. I even think I gave you the points across the top. Just kind of a nice guy like that. I will not accept anything other than what your textbook says for these. You make up your own words like half of you did for GCS, you're going to get no points. Okay? Identical. Make sense? No. Identical. Synonyms. Sea anemones. Now, a couple of these pictures they have great potential, but they're dumb, right? This, what they're talking about is vigorously rubbing the back of the infant to make them breathe. That is not vigorously, right? I mean literally take your entire hand and massage their back to make them breathe, like you do puppies, okay? So if baby comes out not breathing, the very first thing you're going to start doing is drying it, right? Take a blanket and start drying it as quick as you can. That alone normally stimulates them to take their first breath. Make sense? Flick the bottom of their feet. You basically at this point, when you resort to this, you're trying to piss them off, right? You literally want them agitated because crying is breathing. So that's why there was the whole idea of holding them by the feet and spanking them. We no longer, because spanking is abuse in Washington State. Just kidding, it's really not. But drying the kid makes them breathe. Okay, that's the important piece. Your baby's just working on breathing, no big deal. You worry about yourself. Okay, heat retention is a high priority. Yeah. Dry baby, make sure you're not drying it with wet blankets, right? As soon as the blanket gets wet, new blanket. Okay? Then the best thing for baby, once baby's breathing, baby's fine, all this good stuff, those 99.9% of the times, wrap them up in a blanket, cover the head, give baby to mom. Okay? Encourage. Nice work. Good job. High five. Funny, that was your first. It was my first, too. Glad it went okay. Okay, so here's cutting the umbilical cord. Okay, there's always this conversation. Do you let dad cut it? What do you want? If this is the 99.9% that's fine, I don't care if dad cuts the umbilical cord, right? If there's problems, sorry. Make sense? So it's pretty easy, okay? This is not a priority, okay? But once it's time, right, baby's breathing, baby has a pulse, the umbilical cord is no longer pulsating, that kind of stuff, let's go ahead and cut it, okay? So, I thought there was a picture. There you go. First clamp goes 7 inches away from baby. You clamp it, and then you go 2 or 3 inches farther and clamp it, and then you cut in the middle. Why do we leave so much umbilical cord? Say again? So there is lots of blood. What else? You're not at the hospital, so you don't know if they have to take a piece of that. The other one is for us, in order for us to gain access, we have to cut 1 inch off the umbilical cord from where you cut. We have to then clamp and then cut 1 inch off. So if you only give us 4 inches, now we're down to a very small area where the hospital is still going to use some pieces or utilize it for access depending on the circumstances. Okay? Again, it's not a priority, and I will tell you this is not. Looking at umbilical cord, I thought it was like this real fleshy, really delicate thing. When I cut my daughter's, and it's cartilage. I mean, it like cutting like a nylon rope. Okay, it's pretty tough. So resuscitation, there's some unique things about babies and neonates that we're going to talk about. Again, establish that the baby is breathing. Okay? If their breathing sucks, if it's shallow, if it's slow, if they're gasping or not breathing, you ventilate them at a rate of 40 to 60 per minute. That's 1 breath every second. Make sense? I think I have the tape. This is what we're looking for. Okay? So artificial ventilation. If the heart rate is below 100, or if they're not breathing, you bag them at 40 to 60 breaths per minute. Okay? If their heart rate is less than 60, you start chest compressions. Make sense? Now, the ratio of chest compressions to ventilations for neonates only is 3 chest compressions to 1 breath. Okay? So it's chest compressions. 1, 2, 3, bag. 1, 2, 3, bag. 1, 2, 3, bag. 1, 2, 3, bag. Make sense? Yep, encircling thumb. You can use 2 fingers, but it's just preference. Make sense? Good? Heart rate less than 100 or not breathing well, you ventilate them 40 to 60. Heart rate less than 60, you start chest compressions. Your ratio for chest compressions is 3 to 1. Cool? Now, this is why you'll hear most of us say that delivering a baby is a EMT basic skill. Okay? Everything that gets done, except for cardiac drugs and intubating, everything that gets done is done by an EMT. Right? End of this class, after today, you can deliver a baby and you would know everything, all except for when to intubate and what drugs to give. That's it. Everything else that's done is all very, very basic procedures. That's why you hear me always say, oh, you never delivered it. You should take care of them so you just experience this wonderful thing of your life, and I'll drive. I've seen it once. Yeah. Something goes wrong, call a paramedic. I'll drive you there real quick, don't worry. Okay, this is the encircling thumbs. Okay, this is just that, chest compressions for infants. All right, so here's care after delivery. So mom, now this is the downfall, is you just went from 1 patient to 2 patients. Okay? So if you're anticipating a delivery, I would encourage you to take more help with you. Okay? Take a firefighter, take a EMS provider, take somebody with you. Because this increases in patients. That's my rule of thumb. No one ever dies or multiplies in my ambulance. It's the only rule I have. Okay? So mom has a serious risk of infection, bleeding, and embolisms. Okay? All those clots can circulate into her bloodstream and become pulmonary embolisms. Okay? We worry about and kind of pay attention for delivery of placenta. We're going to talk about controlling vaginal bleeding, and then you're going to take care of mom and baby as much as you possibly can. Okay? The good news is women have been having babies without help for a very long time. Okay? You're getting closer and closer. Start stretching. Because today the numbers are going to be triple digits. So, delivering the placenta after birth, right? The placenta with the umbilical cord, amniotic sac, tissues lining the uterus, all that stuff is going to be delivered as well. Okay? So, make sure that you've got gauze pads because there's going to be quite a bit of blood. Okay? Once the baby has been delivered, delivery pains kind of start over again with placenta. This can take a long time. So if you're still waiting around for the placenta to be delivered, after 20 minutes, forget it. Right? Just transport. If it delivers during transport, great. If it doesn't, make sure you let the hospital know. Once it does deliver, it belongs in a bag, right? That's what that bag and OB kit's for, because the hospital then looks at it. Okay? Determines if it's whole, looks at if baby needs any nutrients from it, so on and so forth. Okay? So, a couple of ways you can control vaginal bleeding. Now, is vaginal bleeding normal? Yes. Okay? There's going to be quite a bit of blood there. Okay? If it's continuing, there's a couple things you can do. This is supposed to be massaging the fundus. Okay? Vigorously massage the fundus in attempt to contract that uterus down. Second thing you can do is you can place some padding underneath the legs and put gauze at the opening of the vagina. Okay? Next thing you can do is you can recommend that mom attempts to breastfeed. Okay? By baby breastfeeding, it actually causes contractions that makes that uterus start to contract and slow bleeding. Okay? Now, if mom says, I wasn't planning on breastfeeding, you can respect that, except for the time that I think of is if mom's going to keep bleeding, be like, look, here's the deal. I respect your choice, but this is one way we know to keep you from bleeding as bad as you are right now, right? You don't have to actually breastfeed, right? The first couple times baby breastfeeds, they're not getting breast milk, right? Just that whole process of baby attempting to and mom and that bonding, that alone will decrease the chance of some bleeding. Talk about that. Good. What do you think acts of kindness will be appreciated and remembered mean? What do you think? What's that? Not dropping the baby. What else? What else? Okay, so not reacting to the things they may or may not say to you or the father. What else? Yeah. Yeah, clean them up, right? Replace wet or bloody towels with something new, okay? Do not wrap baby in something that's visibly been saturated with blood or fluids, right? Wrap baby, give them a washcloth for their hands or face. I mean, they've just delivered a, 9-pound bowling ball, okay? They worked hard. Remember those kind of things. Okay? So let's talk about the 1%, okay? And the oh, please no moments. Yeah, notice how it's very PG there. You usually don't say that. What's that? Yeah. Yeah. Praying does help. Right? So here's common complications. Cord wrapped around the neck, unbroken amniotic sac, or infants who need encouragement to breathe. Believe it or not, these are the things, if it's going to be complicated, that you hope for. Okay? Because this is easy. Okay? Take it off the neck, break the amniotic sac, use your BVM. Okay? This is the easy stuff. Make sense? Okay? So, cord on the neck, we're going to notice once the neck is delivered, try to attempt to pull the umbilical cord off. Unbroken amniotic sac, just tear it with your fingers. Infants who need encouragement to breathe, before you start BVMing them, make sure you attempt to dry them and rub their back before you go right to that BVM. Okay? Sometimes it literally just takes you to start rubbing the back of the baby for them to remember, oh yeah, and they start breathing. Okay? Only suction if there's a known problem. So, breech presentation. Okay? This is the most common abnormal delivery. It means they come out butt or legs first. Okay? This is also a lot of times we hear about meconium staining. Babies are not designed to come out backwards. Okay? They don't fit very well. So when baby starts getting smashed into that birth canal, baby starts getting concerned, and then of course meconium staining occurs. Make sense? We're going to talk about that. Most of these, praying helps, because there's almost nothing you can do in the field. Make sense? Okay, this is a breech delivery. Okay, feet first. Okay, note the color. That's normal. Okay, extremities being blue is very, very normal. Don't freak out. Whole baby looks like that, now you have problems. Okay, but notice how nice and pink they are right here. That's because their circulation isn't that great. Okay? I also want to know, where are they at right now? In a hospital. That's where breech deliveries get fixed. Okay? They don't get fixed in the field. Okay? Limb presentation, a limb of the infant protrude from the vagina. Okay? Commonly a foot when baby is in the breech position, but this can be arm first. Okay? It's also not meant to come out arm first. If their arms above their head, they don't fit through the birth canal very well. Okay? Limb presentations and breech presentations cannot be delivered in a pre-hospital setting. Okay? These are the times that you're going to, even though it's technically crowning, right, or you see a limb, you're going to transport. Quickly. Say again? Yep, doesn't matter. So here's the downfall. Can they deliver a baby in the back of a helicopter? Nope. Right? There's no room. There's no seat at the bottom of the stretcher. So you can attempt to fly them. They probably won't fly them. Right? You get to drive them in your ambulance, no matter where they are. They need to go to a hospital. Hopefully the nearest hospital has the capabilities of delivering a child. Okay?
What hospitals don't have the capability of delivering a child?
A critical child, a lot of them. Like a breech delivery, some hospitals may not have the capabilities. A normal delivery, any hospital will take them, right? Because as long as it's normal, like I just said, you don't do anything. It's the breaches, it's the C-section, stuff like that. The hospital's got to have some specialty people there. All the hospitals here would do it, right? Holy Family, Sacred Heart, Valley would all take them. Valley, I think, if I'm right, my mom's going to kill me. I think Valley will do most things except for triplets. Triplets are higher. They require them to go down to Sacred Heart because that increases the chance of baby needing something like a NICU. And the one NICU in Spokane is Sacred Heart, right? Sacred Heart is our level 1 pediatric center. And it's the only level 1 pediatric center through a large area. There's a lot of kids that come into Spokane. Okay? So this is a limb presentation. Neither of them what you want to see. So prolapsed umbilical cord, when the umbilical cord presents first and becomes squeezed between the vaginal wall and the baby's head. Okay? This is also a problem because once that vaginal opening starts contracting, it's going to squeeze the umbilical cord and it's going to cut off blood supply. Okay? That's not good. Okay? So this is the umbilical cord. This is where treatment gets a little bit invasive. Okay? You need to elevate mom's hips, administer oxygen, keep them warm. Okay? You're going to wrap the cord in sterile or moist towels. Okay? You insert 2 fingers to protect the umbilical cord from being squeezed. Okay? Because if it squeezes, once it kinks that cord, baby gets nothing. Right? Baby is literally cut off from oxygen and blood instantly. Okay? Now, these don't deliver in the field very well at all, which means you're in this position all the way to the hospital. Okay? And in most circumstances, when it comes to, we're going to talk about breech that gets all the way to the head. In most circumstances, you, because of the position you're in, go into the OR with them because they're not going to have you move. You hang on to baby until baby is removed. Okay? Breech deliveries have to get C-sectioned and get taken out the other way. Yep, we're going to talk about the times here in a second. Multiple births, this is easy, right? It's a mass casualty, but it's easy. Okay? Make sure you have enough resources. Baby comes out, nothing changes, right? Placenta and cord delivers, cut the umbilical cord. Just make sure you've asked the question, are you expecting more than one child? So it's not like, surprise, there's 4 of them. Okay, premature kids, keep them warm, keep their airway clear. We talked about ventilations and chest compressions. Watch the umbilical cord for any bleeding. Call ahead and make sure the hospital knows that the baby's premature. I was trying to find, I thought I had, I guess not. Book defined premature is anything less than 38 weeks. I think it is. Anything less than 38 weeks or under 5.5 pounds, I think is considered to be premature and underweight. You know what viable is in Washington State? Viable pregnancies. What do you think? It's 22 weeks. Right? Any less than 22 weeks, they don't even attempt resuscitation or transport. At 22 weeks, they will attempt to transport and save that baby. Okay? My dad delivered a 21-and-a-half-week baby that fit in the palm of his hand that was completely transparent. You could see every organ, every bone. Right? That big. Right? Less than a pound. Okay? That's the stuff that, like, MedStar's neonatal team, that's the stuff they deal with. Babies that are that big. It did survive. I don't know long term, but it survived for most of the time my dad checked on it. You call. See what medical direction thinks. MedStar gets to make that decision. Right? Those are the things that those specialty teams, what they're good at. Right? Meconium staining, we talked about it, right? The biggest thing is if you know it's meconium staining, suction the mouth and then the nose. We're going to talk about these individually, okay? Excessive pre-birth bleeding, okay? So this is before delivery even happened. Your biggest concern with any blood loss is shock, right? That's pretty easy and pretty straightforward. Oxygen, transport, place gauze or something over the vaginal opening, and then save any tissue that is passed, right? Because they're going to start testing to find out what we're dealing with. Now, bleeding before baby is born is extremely terrifying to the mom, right? What's the very first thought goes to their head? Baby's dead, right? So now you're going to have to be dealing with that whole process, okay? So don't say things about, don't worry, baby's fine, stay away from stuff like that. We're going to take care of you. Let's get you to the hospital. You know, try to stay as calm as possible. I understand you're scared. Let's get to the hospital. You know, let the doctor talk to you. Let's do some tests. I mean, just work through that process. I would still stay away from that. Just as much as you can, just, yeah, stay away from that whole realm, just for their sake. Ectopic pregnancy, right? Women of childbearing age complaining of lower abdominal pain is an ectopic pregnancy until proven otherwise. Okay? Bleeding, rapid weak pulse, low blood pressure. The biggest thing that is concerning, right, this is 100% lethal to the fetus, and this is a high percentage of killing mom. Okay? If it occurs in the fallopian tube, it's extremely vascular. So when that ruptures, they lose a lot of blood internally. Okay, we talked about preeclampsia, right? So preeclampsia is high blood pressure, and we run a risk of seizures, okay? It looks like CHF. Excessive weight gain, swelling in the face, ankles, hands, and feet, altered mental status, headaches. It presents a lot like CHF. If you transport a patient that's known to be in preeclampsia, your concern is their blood pressure. The other thing that you're attempting to prevent is seizures. Okay? If the patient seizes, they're no longer preeclamptic, they're what's known as eclamptic. Okay? Preeclamptic is just a high blood pressure. Eclampsia is once the seizure occurs. Seizures aren't good for your brain normally. Think about what it does to baby. Okay? So, me and the text, yeah, go ahead.
What can you do for those patients as far as...
Dim lighting, right? Don't turn the lights on in the back of your ambulance. Monitor their blood pressure and transport to the hospital. That's it. Even at the paramedic level, they don't do anything. There's nothing we can do for them. Most of those patients, if they know that they're preeclamptic, are on bed rest anyways, right? So you're just trying to keep them as calm, less movement as possible, stuff along those lines. Me and the textbook disagree, and most of us do. There's a term that's called spontaneous abortion, which is the term that's used for miscarriage. I encourage you to stay away from that term, okay? Use the word miscarriage. If you're going to use a word, do not use the word spontaneous abortion. The only word they hear is the word abortion, which is associated now with an intentional removal of pregnancy, okay? So use terms like miscarriage, okay? These can happen in the field, cramping, abdominal pains, bleeding. Again, now comes the emotional support for mom or dad or family or something along those lines. Okay, trauma in pregnancy, we already talked about, they already have a higher blood volume. They already have a faster heart rate. Okay, so be aware that you may not see the signs and symptoms you're looking for early on in trauma. The one question you're going to ask is, have you received any blows to the abdomen? Okay, been hit, kicked, punched, car wrecks, falls, any sort of trauma. We're going to talk about the traumatic things in pregnancy here. There's one more after this, I think. So ruptured uterus, okay? This is where this only occurs in trauma. This never occurs in a medical or spontaneous setting, okay? What happens is the uterus tears and baby comes out of the uterus and is now just sitting inside that abdominal cavity, okay? This kills 100% of babies and about 99% of mothers, okay? This can occur in the parking lot of an ER, and this will still kill the baby 100% of the time, okay? Instantly, baby is basically dying, okay? The most common time we hear about this is moms who put the lower part of their seatbelt too high up on their belly button, and they get in a car wreck, and that seatbelt cinches down, and it rips that uterus right in half, okay? It's still, yeah, it doesn't. Moms don't realize the bottom part of your seatbelt, the location doesn't change whether you're 9 months or not, right? It belongs on your pelvis, not on your stomach, right? It's not what it's supposed to be. And they tend to put it there because of where their stomach sits. They tend to put that seatbelt real high up. Car accidents, this is really, really common. Also when it comes to domestic violence or trauma, right? A hit, a kick, a punch, something like that, a blow to the abdomen can also cause this. Stillbirth. We do not resuscitate babies if it's obvious the baby has died sometime before the birth. Okay? If it's sometimes if it's occurred a long period before, it can have blisters. It can be black or dark blue in color, like lividity, right? If it's starting to decompose, obviously you're not going to start resuscitative measures. If it's unknown or not obvious that you don't know when this has occurred, you start CPR and you transport. Make sense? Nothing changes. Okay? Still 3 and 1, still 40 to 60 ventilations per minute, chest compressions at the same spot, whole 9 yards. If you have a question of whether or not you want to transport or not, or need to transport or not, call medical direction.
What do you tell mom?
As little as you can, except for we are finding that it's better that they watch your resuscitative measures than it is to kick them out of the room like we used to. Especially with like SIDS cases, we used to kick parents out of the room, do all of our measures, and then have that conversation of, I'm sorry, we've done everything we possibly can, baby's dead. They've seen you do nothing. There's actually proven science that if you let them, as long as they're not a danger to you, let them watch you do all of this, that it actually provides some emotional support. Really good. If you're going to pronounce it, same process. Law enforcement shows up, coroner shows up. Yeah, nothing. It's a dead body. It's no different than any other cardiac arrest. You can ask. Yeah, even 90-year-old people, we ask, do you want them to cover them with our blanket or your blanket, or you would still provide as much comfort as possible. Do you want to hold them? I mean, and I will tell you, it's real important if they picked a name out to call it by the name, not by baby, right? Unless they don't have a name picked out. If they have a name picked out, call it by name. Yeah. Yeah, did you have a name for your baby? If they say yes, then you say, would you like to hold, Bobby or whatever. Okay, cardiac arrest for pregnant women. There is a chance to save unborn children. You hear about these stories in magazines all the time, right? Mom dies, and EMS manages to keep the fetus alive. If you will give mom good air and circulate well, there is that chance that you can save this unborn fetus, okay? Position your hands about 1 to 2 inches higher, because now you've got this baby that sits a little bit higher from the abdomen, and you're just going to provide CPR until either A, you terminate resuscitative efforts, which is only done by a paramedic, or B, you get to the emergency department and they determine they're not going to attempt to pull baby out. Right? Go ahead, Blair. Oh, yeah. Yeah, this is the time to leave. Yeah. Yeah, you transport CPR in this case. This wouldn't be those cases where you wouldn't transport CPR.
Is this where you would take a couple guys from the fire
Mm-hmm. Mm-hmm. I don't know how that works. I don't know. Thank God I've never had to come and I've never dealt with it ever, and I've never talked to anybody who has. You know, we read the stories in the GEMS magazine about Colorado or whatever, where some EMS provider transports mom who died in a car wreck and managed to they do a C-section and pull baby, and baby survives. But I've never dealt with it. I don't know how that whole process works. Mm-hmm. Nope, I know where you're going. Not going to happen. Yeah, too sketchy.
In a rotor, the RN had a bunch of OB experience, and she got medical direction.
A rotor like locally?
No, not here.
Yeah, that I don't know.
LA or something.
Maybe.
And she got the C-section the baby. Mom died because she was unviable anyway.
Right.
And family feud, and lady lost her.
Probably. I will tell you that there's very few places where it's necessary, right? Like in the middle of LA in a helicopter, how many hospitals are in LA? Right? Like, why are you doing that? I can see if you are, some mom stuck, 400 miles in the woods somewhere, maybe. But in that case, you got cell phone service, right? He said if it was true that there was a BLS or a nurse that did an emergency C-section helicopter and then sadly got sued and lost their license. Yeah, it's not in your job description. Most of this is kind of a repeat, so we're going to go through it pretty quickly. Vaginal bleeding, your shock is the most concerning, right? Any trauma, we kind of talked about this already. Any trauma, think about mechanism of injury, be aware of sexual assault, and make sure you utilize law enforcement. With sexual assault, it is a mandatory reporting guideline, right? So you have to report this to law enforcement. Law enforcement will probably have you fill out additional paperwork. Discourage any bathing, voiding, or cleansing of the wounds. If they've already done it, you can't do anything about it, right? So discourage it, but if they've already done it or if they're adamant about it, you really can't do a whole lot, right? If there's a reason to examine the genitals, make sure that it's for a very good reason, like there is a severe injury, and I encourage same-gender providers. Okay? Question? Take like a 5-minute break. We're going to come back and talk about the next thing.